Good afternoon, everybody. I'm Jamie Lozano Carver. I'm the South Plains and Panhandle reporter for the Texas Tribune, based here in Lubbock. And I want to welcome y'all for joining us here in person at the UMC Health and Wellness Hospital in Lubbock. And of course, those of us joining online for our conversation today about how we can strengthen maternal health care in Texas. Our program today will run for about an hour with 45 minutes of conversation moderated by my colleague, Eleanor Klebanoff, and 15 minutes of Q&A. So we can get to as many questions as possible today, we will be doing all of our Q&A through a Q&A portal at texastribune.org/ask. You'll find signage in our space here at UMC Health and Wellness Hospital with a URL and a QR code to make it easier for everybody, but we also have note cards if you would prefer to write a question down for us. We're very grateful for our sponsors, for the support of our sponsors. Our major sponsors are Methodist Healthcare Ministries, St. David's Foundation, Texas Managed Care Alliance, the Texas Hospital Association, Texas Organization of Rural and Community Hospitals, and Texas A&M University Health Rural Engagement Program. Though corporate sponsors and donors underwrite this event, they play no role in determining the content, speakers, or the line of questioning. We also want to thank UMC Health System for hosting us here at UMC Health and Wellness Hospital. And here to offer a quick welcome is President and CEO of UMC Health Systems, Mark Funderburk.
Thank you very much. Good afternoon. Thank you so much for attending today. My name is Mark Funderburk. I'm the President and CEO, and it's my pleasure to welcome you to our Strengthening Maternal Health Care in Texas. I want to take a moment and just orient you to UMC Health System. If you look in your package, you'll see some slides there. I'm going to go through these really quickly, but essentially what I want to tell you is since 1978, UMC has had a very resolute mission. It's been education and charity and financial strength. Education means we are partnering with Texas Tech to educate and prepare tomorrow's healthcare professionals. Charity means we are compassionately caring for our community, for indigent, for unfunded, for the least of these. And then thirdly, financial strength simply means we want to do it as a good steward with as least amount of tax burden as possible for our community and for our citizens. What you'll see on that slide are simply some of the programs and services that we offer. We are very blessed and fortunate to have the dominant market share for births in Lubbock County. We have free doula services. We have breastfeeding services through the Texas 10-Step Plan, and just a lot of wonderful programs that we're able to offer as an academic partner with Texas Tech. On the second slide, speaking of the region, one of our major passions, if you will, is not only excellent care, but also we want to make sure we are providing support for this entire region that we serve. We have 50 to 60 hospitals that send us patients that depend on UMC as a tertiary referral center to be strong for them, and we want to be strong for them. And so we have programs to do outreach and education out in the region beyond maternal care, but for maternal care especially. On that slide, you'll see serving a vast region with the only level 1 trauma in the entire region, the Burn Center, and we serve around 260,000 square miles. So it's a vast space out here or folks coming to us for a variety of reasons, including maternal care. One of the things we're most excited about opening next year, on the next slide, is a picture of our new cancer center. It's gonna open about a year from now in 2026, and it also is built for the entire region. It will be in partnership with Texas Tech. It will have research, phase 1, 2, and 3 trials in the building. It will have integrative medicine, all kind of things we want to have for our patients. Excellent care close to home. And then lastly, the last slide is simply putting a face to our mission. Right now, we're sponsoring and funding 278 residents with Texas Tech Health Sciences Center. And because of those 278, we are able to see some remarkable, wonderful things happen as they go out in the community when they graduate. And one of the best things we've seen recently is our most recent residency program is emergency medicine. And there are 24 students and residents in that program. And the first class graduated, and 3 of those individuals stayed here in West Texas, which is exactly what you want to see happen. So as you see those faces there, just know that's very much our passion. That's who we are. We want to be here for our community, for the entire state. We want to do that through education and charity, and of course, for financial strength. With that being said, that's my introduction, to UMC Health System. And we thank you so much for being here. You're going to enjoy the program very much. Thanks very much. Have a good day. Thank you.
Thank you, Mark, and thank you to all of those around the state who make the journalism of the Tribune, including events like this, possible by becoming Texas Tribune members. To learn more and to become a member, you can visit texastribune.org/support. And tickets are also now on sale for the 15th Texas Tribune Festival on November 13th through the 15th in downtown Austin. TribFest isn't just another political event, it's where big ideas meet real actions. And as attendees, you'll join conversations that help shape the future of education, the economy, energy, technology, culture, and of course, healthcare. So with those driving decisions in Texas and across the nation. Learn more and buy your tickets at tribfest.org. And you can also learn more about our upcoming events around the state at texastribune.org/events. Now, for today's program, I'll start by introducing our panelists, starting with Lisa Dillard. She is the Director of Maternal and Infant Health Initiatives for West Texas March of Dimes, and she is an experienced nurse consultant with a demonstrated history of working in the individual and family services industry. Jill Shanklin is the Vice President for Nursing Excellence at UMC Health System in Lubbock. She oversees the maternal child service line and plays an integral role in UMC's development and engagement of nurse leaders, improvement of clinical quality and safety, and promotion of exceptional patient and family experience. We also have family physician Lauren Swartz, who opened her family medicine and obstetrics practice at the Covenant Healthcare Center of Plainview, where she was previously a resident. She is a graduate of the Texas Tech University Health Sciences Center School of Medicine. And today's moderator is Eleanor Klipanoff, the Texas Tribune's women's health reporter based in Austin. She joined the Tribune in 2021 and was previously with the Kentucky Center for Investigative Reporting in Louisville. I thank our panelists for joining us today, and I turn the program over to Eleanor.
Thank you so much, Jamie, and thank you all for joining us. We are so excited for this conversation. As Jamie said, I cover women's health, which covers a vast array of topics, but access to maternal health care, and particularly in rural areas, is a real area of interest of mine. As Jamie said, I live in Austin. The Texas legislature is in session right now. There's a lot of conversation about maternal health care, not as much as some would like, I imagine. But, it's always interesting to me because in Austin, the conversation is very tangible about, how many hospitals are there? How far do women have to drive? How many, what are the impacts of delayed prenatal care? And the conversations when I go out in communities and report, whether those are urban, suburban, or more frequently rural communities are really, really very different. They're very existential questions about, what does the future of our community look like if we can't literally bring in the next generation? And what does, how are hospitals and doctors keeping the lights on and the doors open? And what does the state value? We talk about moms and babies a lot in this state, and we're excited to sort of talk today about how we can, the state can sort of affirm that commitment with things like dollars and investment in maternal health care. So this is a hugely important topic, and I really appreciate all of y'all coming out today to hear about it, and especially, doing this conversation in Lubbock, sort of the hub for West Texas in many ways for maternal health care. I'm hoping each of you can start and sort of orient us a little bit to the role you play in this ecosystem, and specifically, not just your job title, but the part you play and the patients you see, and then we'll get sort of more into the challenges and the solutions I know y'all are working with every day. So Dr. Swartz, maybe you can start.
Well, mine is probably the most easy to explain. So I'm a full spectrum family medicine physician, and so that means that I do it all. There's not very many of us anymore. That's something that I think we need to work on training. But I'm a Wild West Texas native. I'm from here, and I did medical school here, and I stayed around here. But that's because I always knew that I wanted to practice rural medicine. I saw people not getting the things that they needed. We, did show animals and stuff, and so there was, friends from outlying communities that I had that I saw, that they had some struggles, and they were so close to Lubbock, and so that's something that that I'm always been passionate about. But as far as patients and things, so I see patients in the clinic. I round on patients in the morning. I deliver babies in the hospital. I used to actually do some of the hospital work when I worked at a smaller rural hospital, and we literally did everything. And then I see them, prenatally. I see them before they're even pregnant sometimes. They're my established patients. And then during delivery, and then postpartum, which is actually a really critical issue in rural healthcare, getting people to come back for their postpartum visits, because that's when a lot of maternal deaths happen. And so I guess I'm just involved in all portions of the healthcare with patients from the clinic through the hospital and afterwards.
Right, I mean, full spectrum family medicine being from birth to death.
Yes, yeah.
And everything in between. Yeah.
Yes.
Yes. Jill, maybe you can talk a little bit about your role.
Sure. So I'm Jill Shanklin, and I am the Vice President of Nursing Excellence at UMC. And really my role in overseeing maternal child services began, a few years back. I was the maternal program manager for our level 4 designation at UMC. So for those of you in the room, Mr. Funderburk spoke about trauma designation, and we know that level 1 trauma is the highest level, but it's opposite in maternal. So when you talk about maternal or neonatal care, level 4 is the highest level that a hospital can be designated. So being level 4, we have kind of the opposite end of the spectrum where we have the greatest access to resources and to specialty services for maternal care. And a big component of our level 4 designation is outreach education and support of lower level facilities. So my role, I guess, currently would be more to support that program, support the resources that our team needs to go out into the communities and make sure that we're providing education to providers, that we're providing education to lower level hospitals, but also education to the patients in the communities. We know that a lot of times access is about knowledge, knowing that you need to have prenatal care, knowing that you need a higher level of care than maybe where you're positioned in the state. Being a tertiary care center, we serve all of West Texas into eastern New Mexico, so our patient access is quite broad, and really honored to be able to be part of the collaboratives that work to provide, the best education and support to the moms.
Speaking of some of those collaborations, Lisa.
Thank you, Eleanor. It's good to be here. I will say, I recognize these two ladies up here with me as a result of being with March of Dimes for many, many years at the community level. And as a community health nurse of 35 years, the need was so great for me to not go back to the hospital and work. There are so many opportunities to serve people where they are. And one of the things I learned in my role with March of Dimes is from a national level, there's a whole lot of research going on. There's a whole lot of advocacy going on. And there's a whole lot of opportunity for education. Interpreting all of that from the mile high, in the sky, down to a West Texas regional level, I feel very blessed that our local board of directors and our community partners, one from Plainview, one from Lubbock. We've got partners here from Amarillo, Plainview partners, but our services go as far as everywhere these academic medical centers are. So we have families that we serve in Abilene, Permian Basin, Amarillo, and Lubbock. That's each hub. What we've learned is that families that visit those hubs, they come from out of area, more than half of them. And so when the maternity care desert rolled out a couple of years ago, this was an opportunity for one person to get West Texas and maternal health care out there to others, many others. So we've really promoted sharing what is a maternity healthcare desert. What is, for others, it may sound like a healthcare shortage area, but if you're a rural mom and you're not sure where or when you're going to deliver or when you're going to start care, you're kind of getting off to a rough start. And we've all heard it takes a village. I believe it takes going the extra mile. We've been able to do that to make connections, but we continue to educate moms. There are moms in our panhandle that there was some data years ago, about 33% of the moms at one of the birthing hospitals in Amarillo did not seek prenatal care in Texas, in America, today. This would have been 5 years ago. Just unheard of metric. But for the moms that are worried about delivering on the roadside, and there are a few real-life storytelling moms that have video captions within the Maternity Care Desert Report, that's what they worry about. That affects their cortisol level every day, that they're not sure whether they're going to get the care, be in the right place at the right time, and deliver a healthy baby. And so it's just a tremendous calling to do this work. And we do go the extra mile to reach moms and partners, collaborative partners.
Yeah, I will say when I started asking around about putting together a panel in Lubbock, virtually everyone I talked to was like, well, you have Lisa, of course, right? And I was like, I have Lisa. I promise I have Lisa on the panel. So Lisa is the woman to know in maternal health care in Texas, in West Texas, certainly. I do want to talk about this access to care issue because, at the heart of all of this is healthy moms, healthy babies. Lisa, as you mentioned, almost half of all counties in Texas are maternity care deserts, meaning nowhere to give birth, but also nowhere to access prenatal care. And more than a quarter of rural mothers live more than 30 minutes away from the nearest provider. So, Texas is a giant state. We have large urban centers and vast rural areas. Some of this is, inherent to living in a rural areas. You might have to travel a little further to get health care. But Dr. Swartz, from your perspective, the patients that are coming to you in Plainview and, when you worked in Littlefield, what are the challenges that they're surmounting to even get to you in your?
So they don't always have access to even a car or a ride. They may not have Medicaid yet, so they may not have access to Spartan Bus. That's through the Texas Medicaid stuff. They're coming to me even for their first visit to get a proof of pregnancy to go and wait 30 days to get their Medicaid. And so it's critical that the other person using, if they have one car, get to work, because making those hours that's how they keep their family fed and alive and going. And so it can be a struggle just to even get a ride into our facility. We're in a rural place, but there's even more rural places around us. So we've had people from eastern New Mexico, insurance issues, people from Amarillo, people from small towns that are 30 and 45 minutes away, but it's even farther to get to a tertiary care center like Lubbock. So.
Yeah, and for context to your point about Medicaid, Texas is one of only 10 states that has not expanded Medicaid. We have, last session, legislators voted to extend Medicaid coverage for 12 months postpartum, but most women, we have the highest rate of women that are starting pregnancy uninsured.
Yes.
Yeah.
Yeah, so expansion of Medicaid would be a big thing for legislators to look at, but it's such a multifaceted issue. I think sometimes we think, if we fix this one thing, and it'll just solve all of our problems. It's so complicated. There's so many things and probably so many pieces of legislature that need to be looked at to really shift this in a more positive direction.
Right, if there was a silver bullet, we wouldn't all be
Right.
sitting here, right? Yes. Jill, for you guys in Lubbock, you are taking on a lot of these patients who, maybe haven't been able to get care close to home. How does that affect, how you're working with patients and the care you're able to give them?
So it's multifactorial, because I think that in addition to the patients that come to us, we also, as I mentioned earlier, are doing a lot of going to patients as well, and doing a lot of outreach. And I know that Lisa has spoken to in the past some of the initiatives that March of Dimes and different organizations take to educate patients about the morbidity that that is facing so many of the moms in our region. And so really our focus being on reducing some of those higher risk patients that come to us in the lower level facilities that can handle, a more, I don't know what the word is, like a low risk.
You have to stratify it. Yeah,
right.
it's like a risk stratification. So the handle
The lower risk births. But when you're talking about having a tertiary care center and handling the patients coming in, that's what we want. We really want the higher risk pregnancies, the higher risk for morbidity. You actually do want those patients, even though it is inconvenient, even though it is far, you want them coming to where the resources are. You want them coming to where the specialists are. You want them coming to where we have rapid access to blood products, where we have emergency surgical options, where we have high-level neonatal ICU to treat the babies afterwards. And then our responsibility as a healthcare organization is also to support those families that are coming a long distance, and we have partnerships to do that through Ronald McDonald House to help to alleviate some of the pressures of patients that can't travel back home or need somewhere to stay. And so it's about connecting patients to the resources they need, even if they're having to travel a long distance.
Right, right. Lisa, I mean, your group is very boots on the ground, talking to communities often about what they need. Like, what are you hearing about what those communities need for maternal health, but also like what's working to get people that care?
Oh, that's easy. They need all that.
Okay, great. Perfect. They need it all, and they
there's
need
another,
it now.
There's another list. I think probably the most resonating thing that I've heard over the last 4 years, and I'm purposefully going to ignore the pandemic period, is staffing. And with closures and staff turnover, staff burnout, lack of resources within the hospital to keep the doors open to birth a baby safely, as well as in the clinical setting. Moms from outlying areas still need to be able to make an appointment between 8:30 and 4, and they still need to be on time. And as Dr. Schwartz said, just getting there could be the big undertaking. I think Jill mentioned that critical piece of when there's a maternal case and when it's the mom presenting, she's coming with the baby unless she's already delivered. So we know our NICUs serve a vital role. Half of all the families in there come from out of area. They're taking care of those babies. Those families are still, from their rural settings. But Jill mentioned that advanced care, which is so, so critical. When we have better entry into, and I'm going to shout out to our family medicine providers, when anyone in Texas has a medical home, they're going to present to care with a little bit more ease than someone who's not established a medical home. Families don't know what that means, your medical home. But when you have a provider that's interested in helping you take care of you, you will go back to that provider. I have one upstairs here at UMC. But I will say that if the critical need is there, yes, moms need to know when to be seen, educating them about early warning signs when they're outlying areas, and then helping those that take care of the moms not minimize issues and morbidities that can advance in the postpartum period. So many of the maternal deaths, and this is not just Texas, but nationally, 8 out of 10 are preventable. That falls on all of us. The patient, the people around her, her first provider, her urgent provider, her specialty provider, everyone touching those moms that don't make it. We have missed opportunities. So I think what we all need is a reassessment of where we can fill the gaps. And I think things like this are one way to do it.
Can you talk a little bit, Lisa, about, like, as a very tangible thing you all have done is like just distributing the blood pressure cuffs as an example?
Yeah, self-monitoring blood pressure and screening yourself for depression should not require high-level office visit, maybe one visit to get that set up. But being able to screen yourself empowers you to know what you're looking for and why, and who to call and when to present to what level of care. And not all families can take that engagement of self-care, but we know that Medicaid covers hypertensive self-monitoring devices for the 6 out of 10 moms born who have a baby in Texas. It's covered by Medicaid. So we know that 6 out of 10 of our moms that need a blood pressure device probably should have one. but what we find is they don't. And so through grants and funding and partnerships, we've been able to distribute those through providers. We can screen a mom in a pop-up event in any community, and if we have extra, we can give her one. But empowering those moms to get back to care and empowering their providers to whatever the loophole is, you can get through it for that mom. Once you do it 2 or 3 times, there's an exemplar program in Hereford when we offered them a toolkit on how to coordinate hypertensive measuring devices for their moms. So we know how to do that. She's the expert, and all of our moms that need one have one. I'd never heard or seen that. But we're meeting practicing physicians out in the field and even in Sweetwater, Texas, who take our education on low-dose aspirin to mitigate risk for preeclampsia, which can be a common denominator for a lengthy stay or a preterm birth or a postpartum complication that may not turn out very well at all. And so there's lots of opportunity. I hope I answered that.
Yeah, no, that's great. I think you're right. Like sometimes it can be as simple as giving someone that blood pressure cuff.
I gave one of Lisa's blood pressure cuffs off last week.
That means you have 5 more.
She's coming calling for it to figure out. Yeah.
Well, and similarly, you're educating the patients, but also there is that component of providing education to the facilities as well. So I know that a lot of the partnerships and the expectations for level 4 facilities or level 3 facilities is to go and we provide a lot of education to providers for NRP stabilization. We also provide kits for if there happens to be a severely premature baby that's born in an outlying facility to stabilize that infant until our transport team can get there to bring the baby back into Lubbock, providing the polyurethane bags to keep them warm for temperature regulation and doing lots of different things, even just not necessarily telehealth-wise, but partnership-wise between our providers. So our MFMs at UMC can connect with providers in rural facilities to discuss things like managing hemorrhage or managing a breech presentation or things like that that are emergently happening in a rural community to stabilize the mom or the baby until they can be transferred.
Right, like before the crisis is here, let's make sure we're all on the same page about what we do when there is a crisis. Right. Dr. Swartz, Lisa teed us up very nicely for this. You mentioned staffing and especially, full spectrum family physicians. Talk a little bit about the role specifically that doctors like you play in rural communities and how we can encourage more more medical students to go into that, more residencies to keep them in these communities, and what that kind of looks like.
Okay. Well, so at the risk of sounding like you need to train more people like me, it's true. Yeah. So Texas Tech has really been good about having initiatives to get medical students that want to practice in rural communities. And so I was trained at both UMC and Covenant, and then I did a rural track. And so I got to see all of that and get the best out of all of those things, which was just an amazing experience. So I would say, medical schools like Tech with their rural initiatives and rural programs. That's the one that I'm familiar with. I'm sure there are other medical schools in Texas that have similar things. These hospitals here that are willing to train and kind of go, you're not just OB, we're not gonna, they really embrace you and they're like, you're gonna go out into our communities, you need to know this, and it's really important that you're educated and all of that. And so I think that that's really important. Most residents stay close to where they trained. So residency programs here in Lubbock are really important and really important to support. I would say from a legislative standpoint, it's important to fund those residency programs. Across the nation, we're having issues with funding residency slots, but I would say it's even more important from a rural perspective. The other thing with staffing is keeping all the support staff there. It's hard to be in a rural community. It's really easy to do the same thing over and over again. To know a lot of different things as a doctor or a nurse or an ultrasound tech to be cross-trained is hard, okay? And so you have to be at the top of your game, and it's really can be uncomfortable sometimes. And so it's hard to recruit people and say, look, you have to know all of this. We're not going to pay you as much, and you're going to have less support, okay? Come on, let's do it.
You're going to love it.
So I think some initiatives like that to support nursing and to support, I mean, even the ultrasound technicians to be able to do all that they do is really important. So getting some funding for all of that support staff that it takes is really important. And training physicians, OBs, family medicine doctors, to be in the communities that they're going to and really equipping us with all of that knowledge. One of the things that was great about the rural track was that I got to see, how can we use some of the resources? Like, Jill, I'm blessed to work at Covenant, no offense, UMC, that we have a lot of support. We have a lot of education support. I have an amazing nurse manager here today. She helps facilitate that amongst all of our nurses. And so we have extra education opportunities, but we also have some Texas education opportunities. So things like Texas AIM, they put out toolkits and bundles and things like that. There's some partnership we have at Covenant. You were talking about how to facilitate things. They've come up with a high-risk OB transfer. So we're not calling and fighting for the ambulance with the guy that has a heart attack and the lady who's dilated to a 5 that they're uncomfortable to transfer. And so we have a high-risk OB that comes from Covenant with a nurse on board, L&D nurse to help get those transfers that need to be at a tertiary facility to there very quickly. And I would agree. I think I've talked to the MFMs at both Covenant and UMC in Lubbock, and they're very supportive, really willing to be helpful. And there's not very many of them, so we really appreciate that they always take our calls.
Well, thank you for that. Yeah, I think that's, you and I were talking before this event, about that full spectrum family medicine. Those providers are sort of like the unicorns, and we need more young people. And I think there can sometimes be this disconnect of particularly people in rural areas who want to stay in rural areas, but maybe, like you said, don't have the residency spot or feel like, oh, I'll just do a couple years in Dallas to get, with more support. And then yeah, they get their claws in you. So, I think I appreciate that perspective, particularly on, how we can better fund that. One thing that, both of your facilities have in common that really sort of stands out is your use of doulas and as part of your full spectrum of maternal care. Jill, can you talk a little bit about how you guys use doulas at UMC? And then Dr. Swartz, love to hear from you too.
Sure, yeah. So our doula program has been around since 2010, so we're 15 years old at this point. And it has been just an incredible support of our laboring moms and a recognition of the need to meet a woman where she is during labor. And so our program is provided free of charge to our patients. They register online and then they meet with their doula before they come in for admission. And then that relationship, they are supported prenatally and then during labor and up through recovery. And we last year had 607 of our patients utilized our doula program. We actually are collaborating right now and being able to present in New Orleans in a month or so talking about this doula program. And so it's kind of fresh on the mind just talking about how that culture has integrated into the doulas being really part of our care team, that it's not an individual who's coming alongside as a visitor, but a true member of the medical team providing support to those moms. And our doulas also participate as part of childbirth education for patients to come beforehand to be able to take classes and prepare for birth. We also, part of that department is our lactation services that support moms before, during, and after birth. And you did not have to deliver at our facility to receive service from that team. So it's been just an integral part of our support of moms and of our success in having patients seek us for that program.
Right, and maybe you mentioned this, but it's free of charge to the patient. Yeah, and we should say there's to sort of ties back to the legislature, there is a bill that would fund doulas through Medicaid,
Right.
which certainly would open up more funding for that. We've got some
Which-
quiet applause in the
Yes,
room for
which,
that.
that isn't in existence right now. It's something that really our organization saw as a need for patients and provided as a service to patients. But yes, to have that support for all patients and no matter where they're delivering would be huge.
Right.
So I agree, and if you don't know why doulas are so important, they do things like decrease the rate of C-sections, okay? And so we can have safer vaginal deliveries and things like that. They also help with pain and comfort and just the overall happiness of your birth experience. You want it to be a happy thing and not a traumatic thing. And so doulas are wonderful for that. But traditionally, you've had to have enough money to pay for your own doula. And so it's great that UMC is offering that. We have a newly fledged doula program that our hospital has agreed to pay for. And we've so far had wonderful experiences, really great patient feedback. But yeah, they would be really helpful, if the Medicaid would pay for it.
Sure,
More
yeah.
hospitals can do that. And there is a difference between the doula, like you said, that you bring outside, that you've hired for your own, versus one that is already considered part of the care team and that the hospitals are able to do, or to work with regularly. That said, if rural hospitals are struggling to get just the doctors and the nurses, doula seems like an extra accessory that wouldn't be, and that's not fair to so many rural moms, that they could have a wonderful rural health experience, decreased C-section rates, all these wonderful things, but we need funding for it.
Right, right. Lisa, I'm hoping you can talk a little bit about sort of moving us through the path of maternal care into the postpartum period. I mean, people are having these babies and we are sending them in many cases back out into the rural community they came from with a fresh new little baby, all on their own.
Yes, they do go into the community, and sometimes there's a village for them there, and sometimes they're not. But as my peers said on the panel, having a baby, you desire that to be the best possible outcome. The healthcare provider would appreciate nothing more than a pleasant delivery and excellent outcomes, but we're far from that anywhere you look. But I will say that for the families going home, one of the things we learned in one of the initiatives was Care in the Fourth Trimester, where we did a pilot in 5 communities: Midland, Odessa, Amarillo, Lubbock, Abilene, and we surveyed the moms having gone home. We had subject matter experts in the room from certified nurse midwives, OBs, family med, IBCLC, doulas, mental health specialists, whatever else you need. Not a single provider said no to showing up to educating birthing families. That was a takeaway that was really surprising. What we learned from the families was they are seeking education and information, and the hot topics for the prior year were breastfeeding and mental health. Those won't go away. That might have been the hot topic for what we surveyed them for, but that's a hot topic for every birthing family when they get home. And some of the successful ways to breastfeed a baby start before the last trimester through education, readiness, whether it's peer-to-peer or classes. These classes are not in the rural communities. There is no prenatal education out there other than what you get in the clinic visit or from your aunt or your sister or your friends or Dr. Google, and we don't recommend Dr. Google. But I will say that doulas, there's one other value-added benefit to doula support. Whether the mom has had childbirth education with her partner or not, a doula-supported birth and supporting her plan and putting that baby on skin to skin is a catalyst for breastfeeding. And to be able to do that and know why and when and how, and then in the absence of a board-certified lactation specialist, doulas can fill that gap. So yes, it's not free to have a doula. Someone somewhere is paying for it, but it's very valuable to the hospital, the staff, and the birth family. So it's one of those out-of-the-box workforce pipelines that we do need to invest in. In our part of the state, we need MOS doulas. We need bilingual Spanish-speaking doulas. Why? Because that's the majority of our population. And so there's much opportunity with doulas, but in the clinic settings and where there's no available OB providers, expanding the role of the certified nurse midwife, it has its place and its opportunity to serve and care well for moms until they need to transfer them to that higher level of care. Fills a lot of gaps. Prenatal education, it's nice to have, but for those that don't have it, you don't want a mom postpartum trying to figure out why she's not getting up and getting dressed and feeding her baby. We've waited a little bit long. So mental health is another area through education and self-screening. And then our state and our legislature has done a great job of investing in the Perinatal Access Network for psychiatric services 24/7, 365, no matter if Dr. Swartz is overwhelmed by her patient presentation or those physicians in Amarillo, Lubbock, wherever, you can get a consult. You can present your case. It's not for the patient, it's for the doctor. Present your case and come up with a treatment plan that is far better than doing nothing or sending them to an ED. And so I think we do have and are taking advantage of some of that resources and assets, and the Senate Bill 12 for an extended period of beyond 60 days going to a full year for a mom who is at home with a new baby. She can now address other pre-existing comorbidities such as hypertension or pre-existing mental health and or substance use, and not to mention family planning, so she can space out her babies so that they can get off to the best possible start as a family, no matter where they live.
Absolutely, yeah, thank you for that. Dr. Swartz, can you talk a little bit more about postpartum? I mean, you talked a little bit about even getting people in for the postpartum follow-up visit, but also, one of the common things we do see in that postpartum period is the mental health issues, postpartum depression. What do you see from your patients in terms of even getting them in there, and then once they're in there, sort of addressing the needs that bubble up?
So I think some of it is physician education. I think people don't always ask, oh, and you have a shallow set of questions. I think sometimes moms don't realize that it can show up as just extreme fatigue. You're feeling like you're not getting yourself ready, or just agitation and irritation rather than just extreme sadness. Well, I'm not crying all the time, but they're not themselves and they're not functional. And so just actually taking a second to ask those questions can be really important. I do have support from the Perinatal Access Network. They also have CPAN as their kind of sister program for child psychiatry access. And then mental health, and then we see a lot of hypertensive things afterwards. So we talked about getting those blood pressure cuffs in advance, but also having them come for their follow-ups if they were preeclamptic and they're still having high blood pressures. Is that a chronic hypertension? Are they going to have HELLP syndrome postpartum? Things like that, and making them very aware of what can go on. And it's the follow-up is so important because when you're at the hospital and you have your baby and there's so much information coming at you, you don't always remember all those warning signs to look for afterwards. And it's not just educating the moms, it's, as I mentioned, educating family members outside of that. So sometimes it's programs where you may be speaking to, we did this the other day, we spoke to a set of postmenopausal women, and we did talk a little bit about hey, here are some things that you can look for in your daughters and granddaughters, and warning signs to talk to them about. And so it's not just about educating only moms that have a lot of information coming at, but their village.
Well, and you mentioned earlier, the Texas AIM Collaborative,
Yes.
and one of the things that comes out of those bundles, specifically to hypertension, is also educating providers outside of the maternal realm. So the emergency departments, the urgent cares, things like that, that it's a big component of that bundle that we identify when a patient is presenting if they've delivered in the last 6 weeks, because their symptoms may be presenting like chronic, but they're not. And so really helping providers to be able to recognize a pregnancy-related complication even 6 weeks after delivery is really important too.
Or acute on chronic. So I've had a patient that came into the ER and got admitted to the floor for hypertensive urgency, did have chronic hypertension, but was in the 6 weeks postpartum period. And we have a lovely EMR. Again, I'm blessed to be part of Covenant where we can afford Epic. When I was in Littlefield.
Electronic medical records.
Yes,
Yeah.
you can't afford that. We'll get to that a different.
Yeah.
But it's told me, hey, you're postpartum, this patient, and actually she delivered in Lubbock because she was very high risk, and is in the ER and got admitted to the floor. And I immediately called the hospitalist and I was like, hey, you need to do a pre-E panel, and they hadn't done one. And so it's educating, the ER and the hospitalist
We're in
too.
the midst of building our EPIC OB program right now, and so we're seeing a lot of those triggers and how those are going to really support our providers and patients.
I mean, you guys mentioned the AIM bundles, which are, these set of strategies that the state is sort of pushing on addressing some of the leading causes of maternal mortality, morbidity. I think there's been great success on hemorrhage, on some other leading causes. I mean, I think that's an example of a thing where like the state really, has said like, we want to tackle the root causes of these issues. We want to tackle these issues. We're going to turn it over to questions shortly, but I was hoping maybe each of you could, and I think, the idea, like if you could wave a magic wand, if you could be, in charge for a day, what is something that you wish, the state would throw more weight behind or really start emphasizing in a big way? And Lisa, maybe you can start.
Just all that.
Okay. All the above. Yeah.
I do think our state we may be slow to move, but we do move in the direction of caring for moms and babies. I think with a little bit more funding and a bit more innovation with technology, and I hate to say post-pandemic, but y'all, we went through it and we did pretty good. Take some of those lessons learned. I think especially in our outlying remote areas, we can do so much with telemedicine and pop-up clinics that meet moms where they're at until they can trust the healthcare system, know how to access it, care coordination. But I'd really like to see us invest a little bit more, whether it be pilots, grants, or bills that are passed for innovative funding to do more, and not necessarily more with less, but do more differently. Let's just do it different. And if we've never done it, then let's try something. I know that's asking a lot.
No, I said you can wave a magic wand. You said a little more funding, a few more pilots. You're in charge. You can do whatever you want. But no, that's great. Thank you.
No, I would echo that, and just supporting the organizations that are supporting the patients, and really just to be able to, as Lisa mentioned earlier, being able to find a medical home, being able to support the organization as a whole, because we don't want to stop seeing the patients at the end of birth. We want them to be coming back with their children for pediatric needs. We want to see the moms when they're coming back for, their ongoing gynecology needs. We want to be able to support them throughout the continuum of their life. And so, really being able to support all of the missions from the ground up.
I agree. I think that the perspective you're hearing here that's probably different from the Austin perspective is what you were saying. How far does it for them to get to here? And what we're saying is how about what do we do that they can get their care there? So, how can we have patients get their care where they're at? Because this seems funny to say, but the tertiary care center plan and the way it's set up is expensive and requires a lot of people. And we don't have the funding or the people to do that. So we have to do it differently in a rural community. I feel like my hospital does a really good job of that. And we, sometimes when we're talking to our main branch, we're like, no, this is what we need to do out here. And blissfully, it works. I feel very blessed to be where I'm at. But I have been at a smaller hospital where they struggled to try to do that plan. And so we were getting expensive locums nurses. I won't even tell you how many multiples times the cost that is. And for a facility that has trouble affording to get just regular, everyday employees, getting health care for those employees. There's so many things that go into keeping someone in the community. And it's not because like, oh, those little communities aren't. My community is wonderful. I have beautiful West Texas sunsets. I can take my kids trick-or-treating. I know the people when we go downtown for the parade. I know those people. If there's an event downtown, I'm shopping, and like we all, it's such a family, and there's so much friendliness and love because it's Texas, but so I don't feel like it's the communities that need to be able to go like, oh, how do we draw people? It's how do we afford to keep these people, because obviously it's not just the one thing. It's not just oh, you need to supplement with stipends. It can also be, what, we need to make sure that all those people taking care of our moms and our babies, because we care about moms and babies, also are able to take care of themselves. And so that's why, it's so multifaceted, and so many people are involved. And looking at things like lactation via telemedicine, and but not all of it can be done via telemedicine. So looking at the aspects that can be done like that, developing high-risk OB transport, that sort of thing. I'll tell you, even understanding from our specialists that do support us, we had a locum specialist one time, and we were like, we've got to transfer this baby. They're on CPAP, and they're like, you have a CPAP, you should be fine. And we were like, no, we have a CPAP. Not choosing between this baby and the next baby.
Right.
And so, our specialist understanding like, nope, I'll take it, and that kind of thing.
Right, it takes a lot to sort of understand the whole picture.
It's so many things. It's just so many things.
Right. No, yeah,
All that,
right.
that's just it.
All that, yeah, exactly. Well, thank you guys for that. Jamie's gonna throw some questions from the audience. If you wanna kick us off, Jamie?
Yeah, I will. And just as a reminder for y'all in the room, Matt Ewalt over there has note cards if anybody would like to write a question down. A lot of y'all have already submitted questions online, so thank you very much. This first question is from Annette in Lubbock. She says, more family nurse practitioners are taking rural community leadership roles. What can we do to encourage a national education initiative in maternal health care for rural communities?
So, sorry, just to summarize that question is, how can we sort of encourage education about rural maternal care?
Yes.
Okay, great. Does anyone want to? For FNPs, for family nurse practitioners in particular. Lisa, do you want to talk about the role that some of these other positions can play?
Thank you, Annette, for acknowledging as an advanced practice nurse serving the population. I think there's much you can do, not just through advocacy and continuing education, but if you haven't joined the RH Hub, Rural Health Hub in Texas, resources, learn from others, but as far as professional organizations, I think our own nursing organizations could do a little bit more, and AIM Bundle is just one example. They are adding more and more opportunities for integrating community connections into the care of the birthing family, irregardless of the presenting high-risk complication. I think in advanced practice nursing, your own organization could form a collaborative or a network. Coalitions only work well. One example that comes to mind with the academic researchers up in Amarillo is they have 25 partner organizations, certified nurse midwives and nurse family partnership is in there. Home visitors are in there. Lactation, doula, everyone is at the table on behalf of moms and babies and maternal outcomes. In the absence of that coalition and that shared research, we would not know what to do, how to say it, but we're hearing from the moms too through Vibrant Moms. And if I want to see what's working well in a small region of the state where there's limited resources, an academic research team with community health workers and 25 different organizations show up to navigate much of that. And I'm not saying everyone should sign up to do research. We got to implement some strategies that move the needle. We can't just do research in a lab. We've got to be able to interpret what we're learning and change practice. But I do believe advanced practice nurses do have a place at the table in rural health. They just have to show up or be invited.
Thank you. Jamie?
So Gina from Olney asks if there are any metrics about how the loss of maternity care services affect a hospital's viability and the quality of care that they deliver for the entire community.
Well, I think some of the data does show they had to shut their doors because of the billing, the reimbursement methodology, the equity in that, and then the advanced care and training that it takes to keep a team and an OR ready for a birthing mom in a rural hospital was not feasible. It's why the doors closed. It's not that small communities didn't want to do it, it was not feasible. So reimbursement methodology in some of the smaller communities, there are some bills coming through the legislature that are going to bring some big dollars back to rural hospitals if they're willing to reinvest, reappropriate and allocate in order to serve families locally through either a birthing center or OB services within their hospital line. And time will tell in Olney, Texas. Yeah, I have to hear the name of the hospital sometimes to know where we're talking about,
Yeah,
but
so
I know that's rural.
I actually have some family. It's near Seymour. It's only McGargle, Seymour over there. So you pass through, if you're going from Lubbock to Dallas, you pass through Seymour.
What are your thoughts on this?
So yeah, I think one of the things probably she's getting at too is when you see a rural hospital struggle in general, not just with maternal health, usually because of the poor refund and reimbursement rates, that the maternal health is the first thing to go. It's a sign that your rural hospital is about to close. And so when we see the maternity wards close, then we start seeing the hospitals close. And it's not just maternity care that rural places struggling with, it's all of their health care, and then all of their health care becomes very distant. And so, we should see that as a warning flag, an alarm sign. This isn't good. And that's the thing is it's.
Yeah, the reinvestment, I mean, the crisis is here. Could it get worse? Probably. Will it? I don't know. But without a restart and a reinvestment back into those hospitals that are already there, it's going to take quite a bit of structure and funding, I think, to bring it back.
Right, and I think there's been a lot of talk about that this session about, it's if you think it's hard to keep an OB unit open, imagine how hard it is to reopen one that has closed. There's a lot of push to try to keep these units open. But like you said, I think it's an easy thing to cut because it is often a financial loser, but then it is the canary in the coal mine of, if I'm not delivering my baby there, well, maybe I'll keep driving into the city for pediatrics.
Exactly. So that's something Jill touched on that's what gets your young families in there, and you deliver your baby there, and you bring your baby to care there, and you were seeing doctors at that facility there before, and so it helps keep those families supported.
Right, yes, and certainly, an argument that works a lot in Texas is like the economic development argument of all of this, like keeping families in town and all those good paying jobs we're bringing to Texas need families, willing to live in that community to work there. Jamie, do you want to give us one last question?
Yes, so this is from Cammie here in Lubbock, and she asks, do you feel a 6-week follow-up for moms is sufficient enough for preventing medical complications, or should this be sooner or more frequent when we factor in 3-day follow-ups for babies?
Everyone has answers. Jill, do you want to start us off? Everyone is, yes.
We do actually have follow-ups sooner than 6 weeks. There's certainly for your high-risk moms, of course, they're coming in, sometimes 2 and 3 days after doing wound checks, and certainly for baby follow-up, as the question acknowledged, that we're trying to bring in and establish that lactation support, and also the mental health component has been such a big push. And additionally, one of the Texas A&M components has been on our opioid use disorder and making sure that we're keeping track of that. And so patients that have had C-sections and have been discharged maybe potentially on narcotics, we're certainly bringing those patients in sooner and not sending them home like we used to years ago with, large supplies of, 30 days worth of pain medication, that we're I think that we're doing a good job of increasing that follow-up and making sure that patients are receiving more education in that fourth trimester, as Lisa mentioned. I think that there are obviously so many challenges that we're facing and so many things that the rural communities see that aren't, necessarily happening as pertinent in the hub. But I do want to, I guess, leave with a little bit of optimism that there's so much great work going into it, and the people that are working diligently within these teams really are focusing on the right things and getting the right education out. It's just a matter of getting it dispersed and having the right partners at the table to make sure that it's reaching.
Well, and even ACOG, who our obstetricians learn from and follow standards of practice, has recently changed the standard for postpartum care. There's not a one-size-fits-all, and there's nothing magical about being seen before the 6 week is over. There's nothing magical about that. Customizing and creating the postnatal follow-up that meets the need of the dyad. Sometimes it's more the mom's need, but don't forget there's the baby's need too. And even our family medicine pediatricians can screen for mental health and get billed and bill for it in their private practices or in the clinic. But customizing that postpartum follow-up is more critical, and you can and should customize the visit frequency for when the mom comes back, where and for how long. It'll make a world of difference on screening and intervening if we get off of the 6 week measure.
Dr. Swartz, take us home with
So I agree with all of that. There are individual needs that would necessitate you coming back sooner. If you're having a preeclampsia, we may do blood pressure check days afterwards. That's something actually that can even be coordinated if you end up delivering at a tertiary care center and I'm your doctor in the rural community. So we've had some good communication to do that. But yeah, days after, 2 weeks after, 4 weeks after, 6 weeks after, I had a lady say, like, I cannot come. It is too far. My baby's coming this day. I will come this day. She did feel comfortable. I have a lot of discourse with my patients, and so I really encourage questions and communication. So she was really comfortable. It's like, no, I'm not doing that, And I said, well, could we maybe do a phone chat thing? And so we did a little telehealth visit just to check on her, and or even nurse phone calls and things like that we've done. And so absolutely, no, there's not a one size fits all with the 6 weeks. I think absolutely we customize things to patients more these days.
Thank you for that. And thank you so much for this wonderful conversation. This was really fantastic. And for all the work you three are doing to really advance maternal health care in this area. So thank you all.